These mornings are not possible without the support of our sponsors, so I wanted to take a moment to thank our sponsors. And there are a number of them for this morning. The Canadian Foundation of Healthcare Improvement. I think is Graham in the audience here today? Did he make it? I don't see him. Cerner, Jim Shave. I did see Cerner and Jim Shave here. Jim, you want to put up your hand quickly? Right over there. KPMG, Gordon Burrell, is he here? Did he make it? Yep, right over there. Hiroc, Philip D'Souza is here from Hiroc. Life Labs, Chris Carson, did you make it? And Mario. LBCG, Low Barnes Consulting, Steve Lowe is in the audience here this morning as well. Navarre, Jim Sinclair, Jim, there he is. And NRC, Sonia Jacobs, I believe I did see her this morning. Yep, she is over there. And also want to thank Sick Kids for this morning and the facility, so thank you. So, enough out of me. Without further delay, Dr. Robert Bell.
Thanks, Matthew. I usually don't use slides, but this was such a great opportunity that I made slides. And I want you to know that I'm the minister's delegation. I had the Ontario Digital Health Strategy Board, and I couldn't get my slides here, apparently, Matthew tells me. So that may tell you something about Ontario's digital strategy. So we couldn't get slides. Not true, not true. So it's a really nice time to be here, and thank you, Matthew. Please give my best to Anton and your family for their well-being, and thanks for the opportunity to speak here today, because this is obviously this week a time of transition. And before starting to talk about what we're going to discuss this morning, I want to pay tribute to a few folks, because I was here about a year ago in February, and at that time we were at a certain stage of transition and transformation in the Ontario health system, and now we're at a different stage. And the first thing I want to do is pay tribute to Eric Hoskins, because Eric has obviously been our minister for almost 4 years and has now gone on to chase his passion for completing Medicare with an approach to pharmacare that we hope will be successful over the next year or so. But you know, during his time, Eric demonstrated to me enormous courage for taking on some files that were simply, difficult, tough, risky files. Patients first. Doesn't sound like it's dangerous, but believe me, convincing his colleagues in cabinet, convincing healthcare leaders across Ontario that we needed to bring a focus of integration to our local health integration networks was a tough job. Kids first. OHIP Plus. That was an amazing, amazing piece of work. And certainly getting Ontario at the leading position of moving us toward a national pharmacare program with OHIP Plus was difficult for him to achieve, and certainly puts him in good position for his national leadership position. Other files, the concept that we needed a digital health strategy, the concept of transparency in terms of payments from pharmaceuticals, a number of different files were tough files. And I'd just like to give my thanks. He's obviously not here today, but he'll probably give my thanks and appreciation and say, Eric, you've made Ontario a better health system, and thanks for the courage and energy that you brought to that process. The other thing to say is I've been very, very fortunate during my career to have worked with some amazing leaders. We're here in the Bob Salter Auditorium. I was so fortunate to work with Bob for a year as his lab research fellow. People like Bernie Langer, Alan Hudson. I was talking this morning to Dr. Charles Tater. Just real giants of healthcare, surgery in the Ontario context. Very, very fortunate. But I've learned so much about leadership in the last 4 years since joining the Ministry of Health. And it really bugs my wife, because every night around 10:30, just getting ready to crash in the night, all of a sudden we are the Ontario Ministry of Health. We do still use Blackberries. We're probably the only people in the world who are still addicted to BBM. But about every night, about 10, 10:30, 11, suddenly my BlackBerry starts lighting up. And people across the ministry who are just finishing their day jobs, literally, working on the kinds of things you'd expect at this time of the year, are sending me their daily products. And people in this room, like Nancy Naylor, I know is here, Sharon Lee Smith, Laurel Taylor, Lynn Guerrero, I'll go on and name a bunch of people, but I'll miss a bunch, so I'll just stop there. I can't tell you the kind of values-driven leadership that they bring to your health system with one credo, and that is, if we're doing our job well, we're always below the radar. If we're not doing our job well, we make it to the newspapers, as you've seen a bit recently. So please join me in thanking members of the Ministry of Health. And finally, the other group I wanted, so the last time I was here talking to you, we were talking about Lean transition, right? We were starting that process, merger of the CCACs, and some of you in the audience have had experience with change, you've had experience with integration. I have never seen an integration happen more smoothly. I've never seen it happen with more respect for the people who are moving together, and I've never seen it happen with more focus on ensuring that the 600,000 people a year who get home care in this province continue to receive their care without a ripple, without any missed visits, without anything bad happening. And that was partly due to the ministry's leadership, but I got to tell you, it was really, really due to the leadership of our local health integration networks, who worked so hard under tight timelines and who grew so much. I saw them grow over the last year in terms of their leadership. One of the things that makes me optimistic, and that's part of what I'm going to reflect here, is that the LIN leaders have grown. The LIN leaders understand the importance of integration, and the relationship between the ministry and the LINs has never been stronger. So there are a few LIN leaders here, probably more. Please join me in congratulating them for the successful integration they accomplished. So, my slides are nowhere. God knows where they are. But I have a diagram for you. All right? I got a diagram. I'll pass it around. No, I won't. I'll tell you where it comes from. Because, I'm by background a cancer surgeon. And you can't be a cancer surgeon unless you're an optimist. Full disclosure from the start, I'm about to present you with an optimistic view of what's happening in Ontario's health system today and what we need to do to make it sustainable, to make it higher quality, to make it work better for our clients. It's an optimistic view. There are lots of counterpoints to it. But I think one of the things that we do have progressively is a learning healthcare system. And that's one of the things that I've seen over the last year, is innovation being unlocked through our system. And that sense of learning, of trying, that old PDSA cycle that we all know so well about, is something that's starting to inspire change in our system. So I'm going to tell you what I can remember of the wonderful slides that I put together to show you where we are today. And then I'm going to talk to you about more incrementalism. I'm going to talk to you about the opportunity that we've got within the sub-lesion development, within what I'm going to call to you today and I called last year the care community approach, to talk about tackling issues of health equity, to talk about better ways of understanding opportunity for health improvement, not healthcare improvement. And finally, to talk about suffering. To talk about suffering being recognized in our health system in a different way today than it even was a year ago. And talk about how that concept of sub-LIN alignment, sub-LIN regional planning, sub-LIN care community delivery is something that I think is an absolute answer to our challenges in health equity and to the problem of suffering. And, I'll start off by saying we were challenged this week or last week by The Lancet, challenging the Canadian health system for being perhaps immutable, for not changing fast enough, and of course, for not addressing the big issue in the room. Anytime we talk about equity, and that's care of Indigenous Canadians. The final tribute I'll give to Minister Hoskins is the Ontario First Nations Health Action Plan and the work that Sharon Lee Smith is leading to bring together the governance of the Indigenous Ontario communities with the federal government, with the Ontario government. That, to me, may be Minister Hoskins' actually most sustaining area of leadership. And that is something that we're going to talk a little bit about today. But I want to start off by talking about health, not healthcare. And I'm going to refer you, since I don't have slides to show you, I'll refer you to the website of the Chief Medical Officer of Health, Dave Williams, whose annual report to the legislature is being released publicly this morning in Peterborough, called Improving the Odds, Championing Health Equity in Ontario. And the first slide I was going to show you is this slide. Everybody know this slide from Laura Rosella? Okay, this is Dave Henry, a number of senior leaders. Laura Rosella was the lead author on this paper that was published in BMAJ Open. And what it speaks to is, to me, the big dot for patients first. And that big dot is mortality. If we can improve mortality, if we can improve premature mortality in Ontario, and if we continue to measure that as a big dot and show improvement, surely that's a sign that health's improving. And the reason why I say heroic incrementalism works is the fact that we're seeing improvements in mortality. So, go on Dave's website, go on the Della Lana School website, where the full report is there from Laura and colleagues. But what it tells us is age-adjusted mortality over the last 20 years, and that's half of my practice career, right? That's not a long time. That's half a surgeon's practice career. Age-adjusted mortality for men has improved by 40%, for women has improved by 30%, and premature mortality measured by death under the age of 75, premature mortality has improved for men by 25%, women by 20%. Okay, I'm going home. That's all you need to know. That's how we're doing. And when you think about why that's occurred, I would suggest to you that it's a combination. It's a combination of population health endeavors. It's that heroic incrementalism piece. It's also, however, a tribute to interventionalism, better interventionalism in Ontario. So when we think of some of the ways that our cancer system's improved, when we think of the fact that 5-year cancer survival has improved, I know Linda Rabinick's in the audience. When we think about the heroic effort to eliminate colorectal cancer in Ontario, we're now, Linda, probably about 7 or 8 years into that journey. Yeah, and it's having an impact. No question, it's having an impact. When we think about cervical cancer screening, when we think about the distribution, so I'll let you in on a little comment that I had with Minister Hoskins this week when he was still minister, and he'd come back from a tough time and question period where, I'm going to talk about hospital overcrowding a little bit, if I remember without my slides. But, I said, Minister, the tough thing that you've got, if you were head of a Cleveland Clinic or a Mayo Clinic or a Kaiser Permanente, you would have a discrete boundary around what you're responsible for. You would have control over all that. But Minister, you're responsible for every outcome for 14 million people across all this area and all these different geographic regions and different areas of healthcare leadership. That is truly, truly a tough charge. But when you think about the approach that we've had, starting with Minister Matthews, continuing with Minister Hoskins, when we see interventions like intravascular, transvascular, carotid endarterectomy, it's proven to be effective for patients with major strokes in a Canadian clinical trial involving Ontario and Alberta. And within a year and a half, we're distributing this in organized fashion across Ontario as part of the stroke network. If we look, last year I talked about STEMI. Since that time, we've opened up cardiac intervention centers in Barrie, Sault Ste. Marie. When you think about the access to care, acute intervention that works for populations, that reduces, in the case of acute STMI, the risk of chronic congestive heart failure, early death. That's not good enough just to have in downtown Toronto and the Champlain Lynn. we've got to figure out a way to make that accessible to 14 million people. So, you know, that approach to health equity is part of the reason why I'd say that intervention is continuing to make a difference here. And when I think about the things that we have opportunity to continue that line going down, probably most of them, I believe, fit into that characteristic of incrementalism rather than interventionalism. You know, we can see what happens when we lose track of the change in practice around interventionalism. Recently, you know, the stem cell issue, we need to keep track. We need to keep track of standards. CAR T cells, we need to be thinking about how we're going to implement those interventional concerns as practice changes. But probably, you know, the biggest things that are going to make a difference to these two lines are things like HPV vaccine, and the thing I really want to focus on when I get to the back part of this discussion is the incrementalism associated with self-management, the incrementalism associated with simply getting people to change their behavior. That's what's going to make that line continue to go down. And that's, to me, what Patients First is all about. And that's what this issue of reducing premature mortality is about. Now, if you look at Laura's data, it's fascinating. To look at the Gini, I'll call it the Gini index because it's set on this slide what the actual scale is. Looking at deprivation across the outcomes that people have with premature mortality or age-adjusted mortality. And the first thing that's good is that when you look at the deprivation index and you go from least deprived Rosedale to most deprived living in various rural parts of the province, there's not as much discrepancy between those. The slope across 1 to 5 is nowhere near as steep, of course, as it is in the United States, where it's like, you know, it's an avalanche slope. It's even smaller than a few Western European countries, which surprised me a bit. And you know what the biggest determinant is? If we look at the social determinant elements, we know that the thing that's going to increase premature mortality is going to be income, right? You know that, right? Everybody knows that income equals bad outcome. Not true in Ontario. If you're poor in Toronto, your outcome is better in terms of these statistics than if you live in rural Ontario. So, you know, and that says to me we got to think about healthcare delivery because probably that has something to do with critical behaviors that determine health. We have to think about the challenge across this province. And when we think about the way that we approach this issue with health equity, I think, and this is something I've learned from colleague Nancy Naylor, we think that we need to take an approach, and you need to take an approach equivalent to what happened with school scores, in that improving the outcome of kids in North Toronto on standardized testing for whatever those tests are that our kids take in grade 3 and grade 5 or something. I don't know when they're taking them, but you know, you all know. That's not the way to improve Ontario school scores. The way to improve Ontario school scores is to focus on the low performers, right? Is to bring the Regent Park kids up, the New Canadian kids up, the English as second language kids, to bring those kids up. That's how you improve overall Ontario health scores. And I'm going to suggest to you that one of the best ways that Dr. Williams' report merges with Patients First is it says to us, look at the subregions of Ontario from the perspective of health equity, using big dot indicators that we can all recognize, like premature mortality, and see where the challenges are. And do that analysis in those neighborhoods. And I'll pay tribute to Susan Fitzpatrick, the CEO of the Toronto Central Inn, who's absolutely doing that. She's not just looking at subregions, she's looking at neighborhoods and looking at the discrepancies in health outcome and health equity that occur. So when we're talking about health equity and that challenge, my sense is the incremental approach to improving equity across this province is to do that sub-region analysis and determine where our poor outcomes live and address it there as a starting point. And I'm going to come back to that issue of care communities and sub-region analysis. But before going there, I want to spend a little bit of time on intervention because, focusing on population health, precision population health, individual contribution to population health, we can't forget that we are responsible as well for interventions, and especially the safety, the health, the well-being of Ontario's hospital system. And, we have learned so much this past year. If I had my slide up there that talked to you about how much Ontarians pay for their health care on a per capita basis.
Slides momentarily.
Well, don't bother now. Don't bother now. Because I'll tell you, what I'm telling you is probably wrong if you look at my slide. So Matthew, under no circumstances, I'm on a roll. Don't put up the slide. So if you look at, the issue of overcrowding in Ontario hospitals, relate that to how much Ontarians pay for health care. I think we're around $5,300 per capita. Along with BC, we are the lowest. If you look at Alberta, it's $1,000 more per capita. You translate that to the Ontario fiscal situation. If we provided a healthcare system as costly as Alberta's, we'd have $14 billion more government expense every year. And when you think about the distribution of costs in the Ontario health system, it used to be there were the big three. There were hospitals, there were physicians, and there were drugs. Well, it's now, let me tell you, the big five. You got to add home care to that, and you got to add, especially with the government's announcement of 30,000 new long-term care beds, and the understanding of capacity, you got to add long-term care, you got to add home care to that collection. And there's no question that part of the reason that we're at $5,300 is we have constrained hospital budgets over a 4-year period with no real base increases, some targeted increases, but very little in the way of base increases. We have absolutely had an ongoing tough discussion with the Ontario Medical Association about physician compensation. Fortunately, that's going to be solved. Fortunately, binding arbitration will bring that discussion to a conclusion sometime in the next year, and we'll get back to the partnership between the Ministry of Health and the Ontario Medical Association that's defined our history. Drugs is a great news story right now, The work that Suzanne McGurn has led from Ontario's drug secretary, from our publicly funded drug plan division, leading the Pan-Canadian Pharmaceutical Alliance, working with CADTH, working now with PMPRB, working to actually present to the premiers a plan for national pharmacare. Our Ontario drug plan's work has constrained price, no question, and has improved access. And certainly with OHIP Plus coming to Ontario since January, which again rolled out, boy, you want to think about how effective the Ministry of Health is? That was a great rollout. But our drugs have been constrained. That's been a way that we've stayed at $5,300. The other thing that has defined cost effectiveness in our, I'm going to call it our interventional part of the system, is the fact that despite the fact that our population has been aging very rapidly, we're starting to get into that 75 plus baby boomer creep, that exponential part of the curve. We've kept the same number of long-term care beds in Ontario. We're at the end, just like we're at the end of holding hospitals as tightly constrained as we've had, where also our capacity planning shows we got to start building long-term care. But in between that period, the innovation that has developed, I'm going to focus on two areas of innovation. One, home care, and one, what we're currently learning about surge, hospital surge. So, it used to be, if you go back 5 years, what my slide would show you was that 5 years ago, there were about 50% more. Everybody knows what a MAPLE 4 and 5 is? It's the way you characterize need and activities of daily living, what people need as they become frailer, cognitively impaired as they age. So 5 or 6 years ago, we had about half as many people, MAPLE 4 and 5 in home care, as we had in long-term care. Now, the number of long-term care beds hasn't changed. Today, we have about 20% more people I'm looking at Nancy, about 20%? Yes, she's nodding. About 20%, if you don't bring slides, make sure you bring the smart people you're going to talk about. About 20% more patients who are MAPLE 4 and 5 on home care than in long-term care. So we have used that period of time where long-term care growth has been constrained despite the real explosion of 75-plus-year-old Ontarians to look at innovation, to look at standardization of home care, which is what the integration of CCACs and LHINs was all about, standard contracts, geographic realignment of contracts, levels of care, trying to make sure that everybody in Ontario who needed home care had the same expectations. And that period of innovation has been huge. Pay tribute to the service provider organizations, our old CCACs who contributed to that innovation, as well as our LHINs. But the one thing we've done is we've managed to ensure that going forward, the number of long-term care facilities that we build will be the minimum necessary. And there's no question. Look at long-term care, 52,000 a year. There's some economic point, as well as some point of humanity, where it's appropriate to bring people into long-term care. But we're also doing innovative work now and what we're calling that middle zone. That middle zone between home care at home, which, brings a bit of a risk for the average widowed Ontarian of social isolation. Can't get out, somebody's coming in to, but to the concept of things like naturally occurring retirement communities. And again, I'll pay tribute, Susan, it's a good thing you're here, I can pay tribute to the concept that so many high-rise buildings in public housing, low-income housing in Toronto are really seniors' buildings. And if we recognize that, we can very cost-effectively provide aggregated, congregated home care without moving someone to long-term care and keeping somebody in their residence. And the other thing I want to mention in the way of innovation is what we've learned this year in response to the flu season. We looked at this a year ago. Last year we had a mild flu season. It wasn't terrible. And our hospitals in January and February started to really show signs of strain. And obviously, we couldn't go out and build a couple of hospitals, in the intervening time. But there are 18,000 acute care beds in Ontario. Over the last 6 months, thanks to the leadership of people like Patrick Discerny, Michael Robertson, and the LHIN leaders again, we've opened up 2,000 spaces in the community. Now think about that, 2,000 on 18,000. That's 2,000 incremental spaces designed, of course, to allow patients who are ALC and don't need to be in a hospital, I don't need to explain that to this group, to move to an environment that's different. And what we've done in terms of us being a learning system is we've done that in about 5 or 6 different ways. When hospitals had a vacant ward that could, be reutilized, we've opened up surge within hospitals in high needs areas. Great example is in Barrie. I think we opened up a 42-bed ward that was closed and unfunded. Perfect. We've looked at models of closed hospitals, as you know. The Hillcrest Hospital, I know Marnie Weber's here, reopening that to allow ALC patients to move to Hillcrest from across the Toronto Central LHIN. In Central LHIN, Kim Baker and her team have reopened the old Humber Hospital, as you know, and that's going to grow to over 200 beds, I think, Patrick, over 200. And the amazing thing is, as we open this up, we're starting to hear stories from the terrific team at Humber. Can't pay enough tribute to how they opened that hospital up and how they instigated a new model of care. We're starting to hear about people who are ALC at one of the 5 or 6 Central LHIN hospitals that are participating in the reactivation center. Patients who've been ALC for over a year waiting for long-term care, needs considered to be too great for most long-term care centers, waiting for a special behavior unit, waiting for more support. And they've been at the reactivation center for 2 months, and guess what? They've gone home. So, we're learning that hospitals aren't a great place to be in if you're frail and elderly. Samir Sinha has told us that for years. But, possibly we need an extra step in there, right? Possibly folks can't just go straight home. The Americans have accomplished some of this with their SNF facilities. I think possibly this is an opportunity for us. So certainly what we're learning from Humber, what we're expecting to learn from Hillcrest is certainly part of the strategy that we'll be bringing to bear in the next flu season. The other element of real learning for us has been the innovation that occurs when you bring together great hospital leadership and great community leadership. And I'm referring especially to the facility at Pine Villa, the old Rivera retirement home. It's got about 70 beds. That Sunnybrook has collaborated with Loft and Sprint, two community groups. So patients who are ALC in the hospital are moving to a retirement home where their care is being managed by community providers. So we're going to learn from that. And then the final thing we've learned is of the 2,000 spaces that have opened up out there, we've put in place a lot of novel home care ideas. Some of them use old retirement facilities, some of them use current retirement facilities. When we did that, we thought, again, these patients are ALC patients, they're ALC patients waiting for long-term care. They're going to move into home care, and we're going to see a spike. They'll move into home care, they'll be out of ALC, but they're going to stay there. Probably we'll just be expanding hospital capacity in a way, but that's just about all we'll be doing. Hopefully we'll get through flu season. But what the team told me the other day is that 50% of these people are going home. So again, the concept that a community approach to reactivation, to allowing frail seniors to get the best out of what they can accomplish, probably is something we really need to focus on. And, this thing, flu season is still going. Flu B is still being, still being encountered in emergency departments. However, we're already thinking through the evaluation and how we're going to distribute this resource, what kind of resource we need for next year. I want to talk about surgery for a moment, because one of the best metrics that we've got for understanding the interventional capacity of the province is how many people get canceled for elective surgery because of hospital capacity. And you've seen some terrible tales recently. A poor gentleman in London who had his cardiac surgery canceled 4 times. These are terrible stories that not only are bad for patients. I'll remind you that we're looking after 14 million people, and this is one story. However, that story is not only terrible for that patient, but it destroys faith in our system. When that headline comes out in the local press, when that question is asked in question period, our hearts fall, because we know people reading about that think, what's going to happen to me? What's going to happen to my grandpa? However, having said that, I got to tell you that and I'll tell you, I had a slide up that said, go on ontario.ca/health and look at our Wait 1 and Wait 2 data for surgery. And I think you'll be pleased to see what's happening. In that most of our Wait 1 targets are being hit. That's the time you wait to see a surgeon. Some parts of the province, for example, if you're waiting for a cataract operation in St. Thomas, you're going to wait an awful long time. However, if you're willing to drive 30 kilometers to the Ivy Center, you'll have an international quality care for your cataract in the Ivy Center in St. Joe's Hospital with a very short wait period. But we need to keep our eyes on wait times. But the other thing we need to do is to think about the future of the Canadian surgery emporium, the surgical enterprise. Because as we were planning for surge this year, we looked at all the surge, and this was stimulated by Jack Kitts, who said to us, what's flu season? Well, first of all, we get a lot more people coming in with respiratory illnesses to our emergency department who need GIM beds. The other thing we're trying to do is get all our wait time targets done before March 31st. So, it's like the perfect storm. You're putting all this pressure on Ontario hospitals for a variety of reasons, some of which, can you spread that out over the summertime? Could you work on weekends, surgeons and anesthetists? But The other thing that struck our team when we looked at what surgery is being done, first of all, you know that, like 30 or 40 hospitals are doing the vast majority of surgery in Ontario. So we can readily get our arms around this. When we look at the quality, and this is Lee Fairclough's work with Tim Jackson at UHN, when you look at the quality of care by looking at NSQIP, the National Surgical Quality Improvement Program, and you look at Ontario metrics, we're, I think it's fair to say, on average above the 50th percentile compared to North American centers in terms of all outcome measures. But when you look at how we provide surgery, you say, why can't we be doing this in old Sears and Target stores? Because the vast majority, looking at John, vast majority of what we do can be done at Kensington. The amount of arthroscopy, the amount of shoulder surgery, the amount of lumbar spine, minimally invasive surgery that we're doing in main ORs, the amount of knees that are starting to move to one-day discharge. We've got an opportunity to remake the surgical enterprise in Ontario. I'm being a little facetious about Target stores and Sears stores, but I don't know if you've noticed, there are a lot of open Sears and Target stores out there right now that, we know that Amazon's taking over retail. Why don't we take over the stores that are left behind? Because what do you need for an OR? You need air exchange. You need a processing facility, big open spaces with high ceilings. It's like that old Target store at Thorncliffe Park. So anyway, we need to rethink. We need to purpose build the surgical capacity of the future because there are certain types of surgery that give spectacular outcomes to aging people. Best example, you know what I'm going to say, a total joint, right? A cataract, a total joint, a lumbar spine decompression for spinal stenosis. You turn people who are crippled into active participants in society. And we have to start thinking about how we're going to do that. And I'll tell you, we're not going to do it in the main ORs of Ontario hospitals. Trying to get all our wait times done in January to February when people with flu are coming in. So we need to rethink that. And, this is a great audience to throw an idea out there and see who picks it up and runs with it, right? Because, Women's College is showing you can bring a lot of different surgeons from a lot of different facilities. Kensington is showing you can bring a lot of different surgeons from a lot of different facilities to work in a purpose-built ambulatory facility. So that's part. I want to come to the final part of what I want to talk to you about, and that's incrementalism in care communities. Because when you think about where we're headed with, a population that if we're going to improve that data that Laura Rosella showed us, we need to think about self-management. We need to think about behavior. And we need to think about health literacy as key features that will improve that big dot indicator. And we need to think about identifying where bad outcomes are being achieved, as mentioned earlier. We don't want to look for our lost keys under the street light in Rosedale. We want to look for them, in northwestern Ontario and Indigenous communities. That's where we want to find the keys that are going to open up health equity and better outcomes in Ontario. So what is a care community? I want to focus on this. And how does it relate to suffering? Because I think one of our really big opportunities is to think through suffering in a different way in organizing care pathways and care protocols that today enhance suffering as opposed to improve suffering. So, first of all, care communities. What is in a care community? A care community consists of a bunch of primary care providers today kind of scattered out, non-aligned, not knowing who's on call when, not understanding who's closing at Christmas, not understanding responsibility for making sure the emergency department isn't being used. In our patient surveys, patients, citizens in Ontario are generally satisfied with the health system. They're not satisfied with access to primary care. We know in the Commonwealth Fund, I'm sick and tired of people saying we're the worst in the world. We're not the worst in the world. When it comes to primary care access, which is definitely overweighted in the Commonwealth survey, we're not very good. So primary care, and primary care, I'll tell you, I am so encouraged by the OMA. I don't know how you lift the line in the sand, but the OMA lifting the line in the sand that says OMA members don't get involved with Lynn planning of primary care. You know, thank goodness the OMA really appreciate them saying, let's stop saying that. But at the same time, part of the reason they're saying that is because their members, you know, were getting involved. So we've got Lynn leaders now across the 76 subregions of the province within Lynn's, and they are thinking through the implementation of the Price-Baker report. How do we get coordinated access to primary care not 24 hours a day, but evenings and especially weekends when folks tend to go to the emergency department. That, to me, the engagement of the Society of General Family Practice, this OMA section for family medicine, a huge step forward for us. I'm very, very appreciative of the work of the OMA leadership in allowing that to happen. Organized primary care through nurse practitioner-led clinics. Don Timiansky, congratulations for your role now leading the NPAO. Delighted to work with you, Don. That concept is essential to care communities because linkage to primary care is an essential piece of incrementalism. Because, you know, Danielle Martin's told us in her great book, and we know from research that if we're going to talk about health literacy, if we're going to talk about behavior change, if we're going to talk about chronic disease management, we need to have people who are taking advice from people with whom they have a relationship. You go and you see an internal medicine doc once and he says, take these blood pressure pills. You know, if somebody who you've known for 20 years, who delivered your 2 babies, says to you, you know, your pressure's high, I know, you know the story. Relationship-based care is a major part of incrementalism. The other thing is making our systems more navigable within that care community. And when you talk about a care community, suddenly it probably becomes more navigable. You're not talking about Ontario, you're talking about Toronto East. And, you know, the presence of 5,000 or 6,000 care coordinators now within the LHINs, thinking about the needs, not for everybody, but the needs of frail elderly folks, helping them to navigate the system. That's an essential piece. And finally, this is the entree to talking about suffering. The commitment, another one of Minister Hoskins' big dots, the early stages of a new mental health and addictions policy for Ontario, delivered within care communities, is just an essential piece to thinking about focusing care communities on suffering. Because we know, everybody in this room knows somebody who's suffering, your friends or family, from mood disorder, from mild to moderate to severe mental health. I can see people involuntarily nodding in the room. And we know from the experience in the national health system, we know from the early experience in Australia, that focusing on suffering caused by mental health illness can be a solution, can be something that alleviates suffering. And you know, it's not difficult, right? Well, it is difficult, but you know, I'm not suggesting as an orthopedic surgeon that providing cognitive behavioral therapy is not, God forbid that I would say that. But what I am saying is there's good evidence. There's good evidence from the national health system that 50% of people with mild to moderate and some severe mood disorders, anxiety, depression, can be cured by structured psychotherapy. And a further 15 or 20% can have substantial alleviation of their symptoms through structured psychotherapy. And today in Ontario, you get access to structured psychotherapy on a very hit and miss basis. And I think one of the biggest things that we can do to focus on suffering in Ontario is to think of the organization of mental health and addiction services for people in our care communities and organize them so that everybody working in that care community, care coordinators, primary care, know how to get people into that system. That's not a complex system. Quite often it's 12 hours of structured psychotherapy. So we need to make that happen. We need to make it happen for children, Kim, and we need to make it happen for adults. This needs to be part of an investment in this system. That's my personal view. Not a government view, personal view. The second thing we need to do is focus on a different type of suffering that builds back into mental health and addictions. And now I'm going to rely on my orthopedic roots and say we have this utterly broken method for treating one of the most common causes of human suffering of a less existential variety, and that is shoulder pain, back pain, hip pain, neck pain, all those pains that increase as you get older. And you know, traditionally our pathways have served to medicalize those areas of suffering, right? MRI scans, visit to a surgeon, da-da-da-da. Whereas we got great made in Ontario evidence that these types of suffering can be managed by instruction around self-management techniques, understanding the root of your suffering and illness, and understanding that you can make it better yourself. And if you do need a surgeon to help you, in the rare instance, rapid access to that surgeon. Here we don't have to look in the NHS. We can look in Ontario, the Isaac program, the rapid access to arthroplasty program, and the Champlain Lynn. And here I can tell you, this is not something that's futuristic. $30 million will be invested starting in April, ensuring that every Lynn has an Isaac program, every Lynn has a rapid access program. That suffering is important to alleviate because people don't like to be crippled by knee pain. Has another reason that it's important, and that is the fact that while they're waiting for their MRI, while they're waiting for their inappropriate test or opinion or consult, most of them are taking opioids. The biggest cause of the opioid epidemic in Ontario, in my mind, is inappropriate treatment for musculoskeletal pain. So these areas of focus on suffering require easy to navigate systems, right? And what could be better than care community offering of these? So that every mental health program may not be offered in your care community, but everybody living in this postal code knows where the Isaac program is that they're going to go to, and their primary care provider has the opportunity to link them. And this is not only better care, it will not only alleviate suffering, it's also cost effective. Because, you know, waiting around having 5 primary care visits while you're waiting for your MRI, another 5 primary care visits while you're waiting for your neurosurgical appointment you didn't need, you know, that's not what we need to do. Making health literacy, congregate rehabilitation services available to people suffering from musculoskeletal problems is part of the care community approach that's being implemented in the next year. And finally, you know, our team in the ministry is sick and tired of me talking about these as highly prevalent conditions that are poorly managed, right? So mood disorder, biggest cause of disability in the Canadian economy. Second biggest cause, musculoskeletal pain. Highly prevalent conditions, very, very poorly managed. But the most prevalent condition, poorly managed, is, of course, palliative care. And we know that too many Ontarians die in hospital. We know that too many Ontarians visit emergency departments in their last few weeks of life. You know, the work of the Ontario Palliative Care Network, CCO on one side, LINS on the other, delivery through care communities, focused on hospice, focused on keeping people at home. This is another essential piece of what we need to be doing to alleviate suffering. So, if I had slides, that's what I would have told you. Thank you, Matthew, for the opportunity. And final editorial comment. The coolest thing about this is Dave Williams looks at disparity in health equity not as a population health approach, like an epidemiologist, and says we need to take a disease outbreak and surveillance approach to how we manage health equity challenges in Ontario. So thank you, Matthew. I don't know, we have time for questions? Do we have time for questions?
Absolutely, we've got 10 minutes.
There you go, 10 minutes. Eager to answer any questions. Push the button in front of you. If it's on, you can talk. If it's off, we'll get a coffee. Just yell, just yell. Doris, you must have a comment or a question.
Well, I want actually to know how are you linking or how will be the linkages better than between the poverty strategy and the healthcare strategy, because health is a mix of both.
Yeah, it is.
Certainly more of the first than the second.
So Doris's question is, how do you organize a whole of government approach? I think it's fair to say to poverty to health equity. Well, I think that diagnostic issue that we're seeing from Roselle's work, first of all, of understanding the impact of poverty and understanding the impact of rurality and understanding the terrible impact if those are combined. So that's a bit of a starting point. The second thing is, as a learning system, the guaranteed income that Minister Jacek, who we're delighted to welcome the Ministry of Health as our new minister, led while she was leading MCSS. That's a very unique intervention, the sense of ensuring that Ontarians all have adequate income. We've already seen some of the reports coming out of that suggest that, yes, health improvement is part of the solution. The other thing is bringing people around the table. So when we think about, the care community approaches, this came out of health links, right? And focusing our health links on complex patients, seeing that we needed to have CAS at the table, seeing that we needed to have municipal housing at the table, needed to have education at the table, thinking through the planning of a mental health approach that recognizes for children and adolescents, the diagnoser may be a teacher, thinking through how various ministries have siloed their approaches. So if I was designing a mental health and addictions approach, I'd say probably education should be there, probably MCYF should be there, probably health should be there in a lifespan approach to how things will be offered. So, so we've got a lot of intergovernmental work to do to ensure that when people have problems, they look for solutions as opposed to looking at 4 different ministries for what their offerings are.
About halfway up on your right.
Sir. Oh, hi, how are you? Good to see you.
Given the fact that you're giving this wonderful talk in the Sick Kids Research Institute auditorium, could you say a word on successes and challenges in the care of infants, children, and adolescents in Ontario?
Thank you. Thanks very much, Stan. First of all, I did recognize it was named after Bob Salter, a renowned orthopedic educator. But we've got work to do in terms of organization of pediatric services across the province. But one of the things that we can really speak to is the success of pediatric leadership in stabilizing Ontario's pediatric care networks. And I was talking to Dennis Daneman earlier about the success of the AFP, for example, and ensuring that our academic centers are populated by international experts and Ontarians expect to be looking after and developing new programs of care. We know that the facilities at places like Sick Kids need to be up to date and modern. We need to think the future of things like CAR T cells for pediatric malignancies, as well as, fetal surgery. How's that going to evolve? We also need to recognize how tough it is to be a pediatric provider in the community. The challenges that are there. And we need to recognize that a patient-centered approach to pediatric care is going to define the needs, and Mike Apton's taught me this, of 3 different, groups of children, episodically sick children, children with chronic diseases, and then very high needs kids. And Stan, I apologize I didn't mention it, but that's part of the thinking. How do we develop those networks of care? That's part of what we're thinking about.
Halfway up, middle left.
Sir.
Hi, Dr. Bell. My name is Brent. Thanks for your speech and the examples you gave about heroic incrementalism. I guess my question is really, what ideas do you have for how we can actually do a better job replicating the successes across the province? Because it seems to me that there's a lot of interest in reinventing wheels and very little interest in trying to replicate somebody else's good wheel into the next list.
So
a lot of money on that, and I'm wondering how...
So I would utterly disagree with you in terms of the future of what we're going to try to do. So I'll give you the best example. It probably relates to our digital health strategy, where we're really thinking through, and Jim Shave's in the audience. Thanks, Jim, so much for working with us. The approach to HIS renewal, aggregating multiple hospitals within a single instance that can be cloud-based and updatable. The sense you talked about spread and scale, we do not invest anything in new demonstration. First of all, we will never invest in a pilot project. Those of you dealing with the Ministry of Health, never send us a demonstration project. But as part of that demonstration project, We will not look at it if you don't tell us what the characterization of success is and what the spread and scale strategy is resulting from that success. Best example of that right now is the work that's going on in e-referral in Waterloo, Wellington, Mohammed Al-Arakian putting in place a product that we're evaluating. That product is going to be tried in Waterloo, Wellington for e-referral. It's going to move to Southwest. There are 4 or 5 LHINs attached to that product. If it's successful, there'll be another RFP. Doesn't mean that product's going to go forward, but you know, we're looking at scaling things that we're trying. Ed Brown's been a great example of that. You know, the concept of virtual visits being provided right now, being tried in Central West. If that works, is Ed in the audience? I thought I saw him earlier. Ed's here. So if that works, you know, Ed's got a scale plan for how that moves across the province. So the great relationship between LHIN CEOs and Ministry of Health is such that we will never have innovation that's successful stalled, you know, unless we run out of money, of course. So I think we're done. Thank you very much.
So thank you to Dr. Bell and this morning's event and Sick Kids Hospital. Have a wonderful morning.